Welcome to the third prime time debate dedicated to what did we learn in 30 years of implant dentistry. I'm proud to put you in the hands of our three very excited chairs for this session, Jaime Jill, Iva Milinkovic and Helena Francescu. Good morning to you all, welcome. Jaime, would you like to introduce us into this session?
Yes, please. Good morning, ladies and gentlemen. Standing on the shoulders of giants, Klaus Lang, Christoph Hämmerle, Björn Klinge, Dennis Tarnow, these have been the leaders of implant dentistry, of the research innovations, and the clinical paradigm changes for the last 30 years. And we have the pleasure, the honor, to have them here thanks to the EAO board that has organized this magnificent Congress. Helena, Eva, please, you follow.
Welcome everybody to this amazing Congress and amazing session with these giants. This is an opportunity. We have Christopher Hämmerle from Switzerland. We have Klaus Lang also from Switzerland. We have Björn Klinge from Sweden. And we also have Dennis Tarnow directly from New York. It's 3 o'clock in the morning there. So it will be quite nice discussion about 30 years of implant dentistry.
And we're really looking forward on what we can learn and take home from their 30 years experience of practicing implant dentistry.
We are starting the session with Professor Christoph Hämmerle. Professor Christoph Hämmerle is an honorary member of the EAO and also past president from 2008 to 2010. He is also an enthusiastic motorbike cycler, and he has been the director of the Clinic of Fixed and Removable Prosthodontics at the University of Zurich. Christoph, you are very welcome to start our first lecture today.
Dear ladies and gentlemen, welcome to this session. I hope it will be very interesting, could be very exciting. I thank for the introduction from Jaime Jill. I'm not sure that I am a giant. I have had the chance to contribute to the field and to the developments, but this due to the fact that I had the chance to be part of a wonderful team, starting in Bern with Klaus Lang, and then in Zurich at the Clinic of Reconstructive Dentistry with a wonderful team. This is where the information originated from all this teamwork. Here are 3 implant systems, the Tübinger immediate implant, the Brånemark implant, and the ITI implant system. On the left side, you see the Tübinger immediate implant. It's a ceramic implant. In the middle, you see the Brånemark implant, the machined implant, and on the right side, you see the ITI implant with a TPS surface. These were independent developments. One was aimed at immediately replacing teeth. So 30 years ago, and more than 30 years ago, these ideas were already there. Of course, we have learned a lot on how to manage implant placement in extraction sockets, how to find indications, how to place the implant, how to manage the tissues, and how to do the reconstructions. So the original ideas go back a long way, but the elaboration and the development of the techniques, this is why we stand at a completely different time point and completely different success rates with our patients. The Brånemark implant, originally for edentulous people, full arch, with a lot of complication when it comes to technical aspects. It was a revolution. Today, we also treat a lot of patients who are edentulous with much better concepts, but still the same basic idea. And on the right side, the ITI implant. This was developed for partially edentulous patients, for short-span bridges, for single-tooth implants. So all this was covered many years back. Now let's look at some aspects. There was the quest for the optimal surface, and Klaus Lang will speak more about this. We have learned a lot about bone integration, and I think there has been a major change in how we work today. Short and narrow implants and few implants are very common in our clinical practice. This was something unthinkable 30 years ago. when we placed as many as possible and as long as possible. So there has been a major shift in the way patients are treated. And I refer you to Nissan and Renoir, short implants in limited bone volume, something very interesting, not only looking at hardware, but also at how we work, how implant dentistry is spread in the community of clinicians. Here's a study by Papaspiridakos. It's a meta-analysis of short implants, comparing them to longer implants. Apart from the content, it's also important to notice that here we look at 10 randomized controlled clinical trials. In the early days, there were cohort studies trying to find out, does it work? Today, we compare different concepts in randomized studies in order to improve the concepts that we have. And here's one of these studies. You see that there was sinus floor, sinus area in the posterior maxilla, a randomization in short implant or sinus lift with a longer implant. And just very briefly, clinical and patient-reported outcome measures, very high survival rates, 100% and 99% in one and the other group. And if we look at the differences, bone levels were the same, but the morbidity for the patients had decreased by 50% when using the short implant. The costs had increased 100% when using the sinus floor elevation, and the surgical time also increased by 50%. So a lot of the quest in these 30 years has been to maintain the predictability, but to decrease the morbidity, the costs, the time, and all these factors. And a lot of this is done with these randomized studies. More of these studies that look at implants in the posterior mandible, either vertical augmentation and longer implants or shorter implants. A very similar picture. So big change has happened there. Shorter implants, less implants, and also in some cases, narrow implants. This was an evolution, but here we have a revolution. The GBR revolution. It goes back to studies in the late 80s and the early 90s, where we learned that with this technique of guided bone regeneration, we can generate bone where we need bone to place implants and around exposed surfaces of implants. And it goes back to Sture Niemann and Torkild Karing, who also looked at previous studies that were done in the field of periodontology and in the field of bone healing. And they understood that this could have a very high value for clinical dentistry. On the left side, the image at that time, or just before, the only thing to be done was to do a bridge there. So to cut 2 teeth, and with guided bone regeneration, we had the chance to augment bone. Here you see implants placed in a deficient ridge. They're placed according to the prosthetic plan. Before GBR, implants were placed into the host bone where there was bone to cover them all around. And with GBR, we could place the implants where we needed them from a prosthetic point of view. GBR was then performed, and please observe on the right side with the temporary how perfectly the implants are placed underneath the reconstructions. And remember, the patients come to see us because they want reconstructions. So this is the ultimate goal. Today, there are no self-driving cars, but you can see this short video on YouTube, and it's a gentleman driving with his Tesla to work without ever touching the wheel. But supporting system allowed driving 4 times as many kilometers without an accident as compared to cars without these systems. They're not self-driving, but they're supporting us. And this is what we are seeing now also with the computers, novel in dentistry. This is a full zirconia reconstruction. It was 20 years ago that there was a breakthrough. And you see that the different ceramics here, with their physical properties, the zirconia is completely different from everything else we had before. And it's thanks to the new manufacturing processes that are CNC, computer numeric control. So the computers made new treatment modalities available that were not available beforehand. And this, I think, is the second revolution. It comes slowly, but it's an important change and not only in dentistry, but also in society. Quality control, improved management of production process by numeric control of design features based on physical properties of the materials. So the computer will not allow us to do certain mistakes that were done in the past when manufacturing reconstructions. Or the planning tools that support us. They really give us new possibilities for quality control and management. And soon artificial intelligence will bring all this to a new level of quality, a new level of safety in clinical practice. The aim is still the same, to place the implants where we need them for the reconstruction, and as you can see here, need for bone regeneration. An outlook, navigated implant placement. We see this comes up as something very important. Again, it's an incremental step. It comes with additional computing power, and also robots. Robots are computers that have a physical arm in the real world. And they're robots that have placed several thousand implants. And finally, a very important shift that I see as well is from specialized centers of implant placement to general practice. Initially, it was only oral maxillofacial surgeons, specialized periodontists, surgeons, maybe also from other fields, that were at all allowed to place implants. And as we have more knowledge, we know more about the risk factors, how to control them. The materials have evolved. There has been this important shift into general practice. This is important, and this is very good that this is happening, but it also brings challenges. So there's a need to standardize and simplify equipment and parts needed to treat patients. Because people who place implants don't place hundreds. They may be dozens in a year. Simplify and standardize the clinical procedures for diagnosing, planning, and execution of treatment. And a lot of this is happening. It's happening every day. There's improvements all the time. Make it more simple and more predictable. Improve the supporting systems for stepwise quality control. And I have alluded to the planning, to the computer quality control during all the therapeutic processes. And in order to really implement this, we need new channels for communication and also for local support. And we need to tailor the educational offerings towards professionals in general dental practice by applying online and blended learning concepts. And there's many more changes coming. We're working at them, and a lot has happened in these past 30 years. So in summary, we looked at treatment possibilities based on refined clinical concepts and the technical developments. We've looked at the revolution of bone regeneration. And we're now in the era of another revolution, the era of computer technologies and digital data management. And the fourth element was the shift of implant dentistry as a commodity into general dental practice. Personally, I feel that implant dentistry has come a long way in these 30 years, but it has never been more exciting than it is today. And I hope we can all share this excitement and talk more about this as we are on stage with the panel. Thank you very much for your kind attention.
Thank you very much, Professor Hämmerle, for such a didactic, excellent lecture. Now Eva will present our following speaker, Professor Björn Klinge.
At this point, I would like to invite Björn Klinge, Professor of Periodontology of the Faculty of Odontology of Malmö University, as well as Professor at the Department of Periodontology at Karolinska University in Stockholm, to proceed to the stage. Professor Björn Klinge has been Dean of both universities. He has served as EAO President from 2014 to 2016. He has been the president of several societies in the field of periodontology and implant dentistry, which leads us to a conclusion that he has left a tremendous impact on these two disciplines. Besides being a passionate sailor, I have to add that Professor Klinge has been the person who has always, on a professional and personal level, helped us people of the younger generation, give us the wind to our sails and help us to learn how to sail. So Professor Klinge, please share with us your presentation.
Thank you so much for this wonderful introduction. I was just looking if there was someone next to me who was presented here, but finally I realized that years have gone by. It's fantastic to have the opportunity to meet you all here in Geneva and also some additional in web. Let me go back a little bit in history. I started as a student teacher in anatomy at Lund University, and as you most likely know, that's where Professor Brånemark had his initial studies and research, and the first studies finding that titanium was stuck into a rabbit. And the same staff were still there. Brånemark had moved to Gothenburg when I was there, but the same staff were there. So I was told some of the original kind of untold stories of Brånemark, and I later confronted him with that. He was not necessarily pleased that I knew all the details, but that was for me something fascinating. I graduated, started my research project in Perio, had my PhD, and started my specialization in periodontology. Part of the specialization was to spend some time at the clinic of oral and maxillofacial surgery, and I went to such a clinic, and this is now in the beginning of opening up implant dentistry in Sweden. So at that clinic, Halmstad Oral Maxillofacial Clinic, I had the opportunity to stay there, not for 3 months, that was the intention, but for 3 years, and be exposed to more or less daily activities when it came to implant dentistry. I had one problem. At that time, it was only allowed for oral and maxillofacial surgeons in Sweden to place implants, and the prosthodontics should be handled by prosthodontists. I was an outsider. I was a periodontist. So I applied to the Brånemark course in Gothenburg. That was mandatory if you were supposed to get equipment and implants. And they were a little bit hesitant to let a quasi-surgeon in there. But since I had these 3 years, I was allowed to get in. If I sat at the back of the hall, keeping quiet this week, not interfering with the surgeons and the prosthodontist. And I sat there quiet the whole week, but at the end of the week, I rose my hand, and the panel of all these experts were up front, and I said, "What about probing?" And I tell you, it's a miracle that I am alive, because could they have killed me with their views, kind of confirming that why did we let this idiot in here discussing probing? What relevance does it have, placing implants and probing? But we'll come back to that. That was a learning lesson. And for some, obviously, the coin has not fallen down yet. I would like to bring out a few things that has happened during this 30 years period. And one of them is, of course, the continuous flow of scientific reports on the outcome of treatment. And as you can notice here with the increasing bars, the height of the bars, is that 30 years ago, there were basically none or very few scientific publications when it comes to dental implant treatment and implant success. And at the far end of this graph, you notice that last year there were more than 500 publications on this limited subject dealing with implants and how they succeed. I just brought up a few sentences from some of this available scientific material. And in this systematic review paper, where they evaluated the survival and success rate of dental implants, for a long period, they concluded that we may affirm that osseointegrated implants are safe and present high survival rates and minimal marginal bone resorption in the long term. So that's kind of a safety for all of us, and most of us being present at the EAO conference are quite confident with the good outcome of treatment. But yes, there is scientific backing to this in long-term clinical studies. So far, so good. In this 30-year period, we have kind of been able to conclude that this is a very good method. And then, of course, as has been pointed out by Christoph Hämmerle in the previous presentation, we went from the totally edentulous patient now to perhaps more single teeth replacement by implants. And it's important also to test how does the different methods use if we are using early or delayed implants. And again, it has been shown by the available scientific literature that early implant loading should achieve the same clinical efficacy as the delayed loading method. We may come back to this in the discussion period. And something to be kept at the back of your mind is, however, that even if there is an enormous flow of scientific literature and material, there are still shortcomings in the available material. So when Irena Seidler and her co-workers looked into this, they said that the assessment methods, how they evaluate the outcome, has a great heterogeneity. That means that they are looking at different things. It's hard to combine the data available, not often clearly defining what is the primary outcome. And when it comes to prosthetic outcomes, implant survival, and patient-reported or related outcomes is very infrequently reported. So despite all the number of papers being published, we still need a lot of important information to be able to be safe with what we do. Jumping to a totally different area, again touched upon by Christoph, an opening for the future, but a little warning flag. The commercial advertising is, if you never placed an implant before, try this. It more or less will do it for you. And I think that there are reasons, despite the enormous development into the digital world, that still we are clinicians with a patient. We may go for the robotic, but we're not quite there yet. And still, if you're using the robot technique, you may need to be able to evaluate and assess what you're doing. So my little comment is that, yes, happily, all the digital development, and of course the industry is the driving force, but it should be on the back of your mind that it might be helpful to know a little bit about the biology. Another step into history is that for the first time in 1987, in a paper by Andrea Mobelli and senior author Klaus Lang, the microbiota associated with successful or failing implants was mentioned, peri-implantitis. And yet today, it seems to be a little bit of an academic dispute, and for us being presented with the cases in the clinic, we can see that this is a cumulative clinical problem. So coming back to the necessity of assessing the tissues using the probe. And of course, this is mandatory for all follow-up of the implant placement, that you assess the tissues by probing and, of course, radiographs. Now, another area is that we have the peri-implantitis, we have the disease-associated biofilm that will increase inflammation. This will lead to a circulating bacteria in the bloodstream, and that also, as periodontitis does, may affect the systemic inflammation and related comorbidities. until now, it seems as the human body is divided in two pieces. One is the whole body for the physicians. The other is the oral cavity for dentistry, and not necessarily communicating fully about what can happen. So I think that there are reasons to understand that the mouth is a part of the body, and what happens in the mouth when it comes to infection and inflammation may affect other parts of the body. And going back to infection, inflammation around implants also may affect this. One thing that is kind of the key message learned throughout these 30 years is that for every implant patient, of course, supportive treatment is mandatory, and it is mandatory to include the patient in his or her successful outcome of this treatment. Sometimes in conferences it might be that the audience is left with the impression that, oh, he was quite negative there. He was bringing up the oral systemic link, and he was bringing up the risk for peri-implantitis to destroy the implant constructions. He is extremely positive, talking about myself, about what implant dentistry has added to our professional life, of course, but also to the quality of life for patients. So I would like to end this presentation with a 30-year experience. I installed these fixtures in 1985. It was the first test that we did in the clinic on partially edentulous patients. Then I was phoned up by a colleague, Dr. Pontus Skolander, and he said, in my chair I have one of your old patients. I said, no problems again. He said, no, the patient is extremely happy, and she has asked me to send you clinical pictures and a radiograph of what you did 30 years ago. So there is still hope. Thank you for your attention.
Thank you, Professor Klinge, for this excellent lecture and for your remarkable sense of humor.
I also think that we have had a chance to take out some key points out of your lecture. I'm really happy that you stressed out the importance of maintenance, and I think that we will have the time in discussion to elaborate this a little bit, because it is really an important message to be sent. So, are we going overseas, Helena?
Yes, we are. We are flying out directly to New York. So we are lucky enough to have our presenter directly from New York. I will remind you, it's 3 o'clock. He has a lot of coffee next to him right now. And Dennis Tarnow doesn't need any introduction. Dennis Tarnow is currently the director of the implant program at Columbia University. He was also in charge for more than 20 years for the implant program at New York University. He has published more than 100 articles in the field of implant dentistry, periodontics, and prosthodontics. He is a brilliant clinician, as you know. He's a wonderful educator and mentor, and besides all that, he is also known as the Papilla Man, the Yo-Yo Club president, or the Banana Man, or the 1.5 to 2 millimeter man. You want to know more? Just Google Dr. Dennis Tarnow. So, ladies and gentlemen, directly from New York City, the one-of-a-kind and a true inspiration, Dr. Dennis Tarnow.
Good morning, everybody. And Helena, thank you so much. You're one of my proudest times is to be introduced by someone like yourself. Can everybody hear me all right? Everybody okay?
Yes.
Great. So thanks so much for that. By the way, there's 250 publications. We've got to update my CV. Okay. Let me go. What a great opportunity to speak with everybody, and a great honor to be with such prestigious people like Klaus, Björn, and Christoph. It's my honor to be here today. And thank, just to everybody at the conference. I'm sorry I couldn't be there, but my thoughts are with you. So we have a limited time. The first problem I have is the title. What have we learned in 30 years? Well, it's much more than 30 years. I'm going to bring up 60 years of my topic was going to be macro and microscopic geometry of implants in the 12 minutes that we have. And I put down where we were, where we are, and where we're going. Now, I've been doing implants. I was trained by Brandemark in 1982 with George Zalb in Toronto. So my first implants were 1982, which is really 40 years ago. Why do I say 60 years ago? First, where were we? Take a look at these implants that were available 50, 60 years ago. This is 60 years ago from a textbook. And what you see is a whole group of things. Now, I know we have a lot of Italians and Europeans, of course, there. I just know when I look at these implants, these are dental implants. I could just picture two of my Italian colleagues who just went to have a nice dinner, and they looked at the waiter opening a cork in a bottle, and I could just see them looking at that. Ooh, look at that. See the way they screw that in? Maybe we should do that in the bone, you know? And I just see that these are the pioneers. And some of these did take. Some of them, because they were hand torqued in, they didn't burn the bone. And some of them took. And we'll talk about that in a second. But I want you to see where we are. This is 60 years ago. Take a look at this. Take a look at that shape. Does it look familiar to something recent today? That was the original Tremonti screw, 1963. So that's 60 years ago, and along with all these others. And the Tremonti screw is very popular in Italy. And so you take a look at that shape. It's very self-tapping, one-piece construction. Rather interesting. However, you don't see it today, do you? Or do we? Let's take a look at a very modern implant today. If you look at the design of a modern one-piece implant today, or two-piece, but it's pretty similar. Now, they spent millions of dollars investing into this design and gave somebody a design. All they had to do was go back 60 years ago, and they had the design already there. Now, why is the one on the right not available anymore? It's not available anymore because it had what? It had the right shape in many respects, self-tapping, and it could be used. But what was the problem? It was the fact that it was polished. At that point, that was the biggest mistake of all these implants. Most of them were polished. And so what happens with a polished implant? Wrong texture, same thing with blades. This is from Lenny Linkow's group of blades, along with the 30 or 40 others that he had patents on, including screws, by the way, and he doesn't get enough credit for that. He had patents on all of these things, including the original self-tapping screw, by the way. So if you take a look at the history of macroscopic things, they were the wrong texture, and of course they were improperly loaded. Except if you take a look at when he went around the whole turn of the arch, 1992 is when he published this, and 20 years before, that's 1971, you take a look at this article that we published on, look at this, 4 blades. He put it in, this is from his picture, 1971. That's his numbers right there. He put that on the sheet. And he put in 4 blades and immediately loaded them. Sound familiar? 1971. That's before all of us were even thinking about implants. Now, he had failures. He had fibrous encapsulation, and that's why the blades didn't work. But if they were textured, and he went around the turn of the arch, he got integration. And that's what he taught me many years ago. And this is 19 years later, this fracture. See, this post-fracture, fatigue fracture. Immediate loading, 20 years. And he took this implant out. And I even helped him with this. And look at this. This is the blade. Now, I would defy any one of you to say that that's not integration. That's a blade that was put in 1971, immediately loaded. And there's 20 years later. And that is beautiful integration equal to anything that you'll see today. Time to reevaluate and think. It's not the shape of what we put in, it's whether there was texture. And we say, where are we today? So, of course, we have Brandemark's original definition of osseointegration, but that's on the light microscope level. On the electron microscope level, we have to put in on the light microscope level, because as we know, it's really not touching the implant. On the electron microscope level, you have the titanium oxide, and then there's a glycoprotein material like chondroitin sulfate or hyaluronic acid between the bone and the implant. And that changes over time. It's dynamic. And I've always tell my students, it's not a piece of wood that you're putting this implant into, even though it might feel that way. It's not. That's just initial stabilization, like a wood screw. But the real reality is that that's an ongoing interchange. And as you all know now, that oxide layer changes over time in a successful implant. And it increases in its thickness. In that electron microscope, it's angstroms, but it increases in thickness. So we now know that it's dynamic and keeps changing in our bodies. And take a look at this picture. Bob Jaffe gave me this picture when he did a one-piece implant. This was, you can see the one-piece implant with the machine top. That was the one on the right that somebody put in here years ago before he was putting in two-piece implants. And look at where the bone is. Now, that's the same titanium implant here on the right versus here, but one, obviously the bottom was textured and the top was polished, not machined. It was more very smooth. And so wherever the smooth collar was, what happened? The bone would follow all the way down. And so they lost bone. So it's not just the titanium necessary for integration. Here's the same titanium on the same implant, and it didn't integrate, and it won't. And so this is what you must realize. You need some texture, at least the machine texture that Björn gave us with his implant was at least machine. So what is osseointegration? It's mechanical locking of a surface that is biologically acceptable, whether it be titanium, zirconia, tantalum, gold, yes, gold, yeah, that can integrate too. And this is the famous 3 threads that Björn showed us. And if you go to Albertson's wonderful article on surface roughness, the SA or RA value, the vertical height of the average vertical depth of the bumps that we get on the surface. Surface roughness is smooth if it's less than 5/10 of a micron. Minimally rough, 5/10 to 1 millimeter. Moderately rough, 1.1 to 2, which is what most of us use today for most implants. And then rough would be more than 2 microns in vertical depth of the surfaces. And if you look at what each one is, where do we have smooth? Obviously, our polished abutments, TADs for orthodontics, and bone screws. You ever wonder why you put a bone screw in for a bone block and then you can take it out in 6 months? Because it's not integrated. It just gives you mechanical locking. Same thing with the TAD. Machine surface was 0.5 to 1. The machine surface was 0.5 to 1 micron. The machine surface, as you see, like the Björn original implant, is rough enough to integrate, but not that well in soft bone. So we went to moderately rough, like SLA, Tioblast, RBM, and rough surfaces were too rough. The TPS, which can mechanically integrate, was periodontally a problem if it got exposed. So this is another whole thing. So, and here you see gold. Abramson and Cardopoly showed that you can have gold integrate too. So it's not just titanium. And you can see, look at the beautiful integration on both. And there's all kinds of different shapes. There's over 250 implants probably that I can count. And now we have short ones, as you all know, 5 millimeters, 6 millimeters, as you see here. We have fat ones. We have wide bodies, 8, 9 millimeters. I never thought I'd put an implant in that's 9 millimeters wide and 7 millimeters long, wider than it is short. Similar to what Linkout did with the blade. It was narrower than it was long, and it was narrower and thinner and wide with different shapes. So there's all things learned. So there is a paradigm shift from the original Björn machine implant to textures, increased thread pattern, and here's something different colors at the top, anodized tops, and here's something different too. You got a different reduction at the top. Instead of engaging the top, now we're looking at maybe more space for more bone to fill in, especially with immediates. So you got implants like this, you got implants like this, my partner Steve Chu, came up with, and there's more bone and maybe better prevention for future aesthetic problems when bone changes over time, similar to what Oded Bahat has shown us. And so then there's the other part is the surface texture. There's the machined on the left, acid etched, and there's an anodized surface on the right. Now, these are all different surfaces. And what you see here is the plaque on an anodized surface. And this has been a nightmare. When this surface is great for bone because it'll mechanically lock in. So rough is always great for bone. So we have two things with an implant. One is, of course, the mechanical integration during the healing, 6 to 8 weeks. But the other one is what happens if it gets exposed. And this is a nightmare. Look at the caves. So we don't want that near the top of an implant. So that's when 30 years ago, in 1993, I came up with the hybrid concept. Use the machine top, which can integrate, but is not prone to periimplantitis if it gets exposed. It's minimally rough, but not smooth. It's machined. And then use whatever rough surface you want on the bottom 2/3. So this is what I came up with in 1993. And apparently it's very hot now, isn't it? Because now this is caught up to everybody. It's called periimplantitis, which I'm sure we'll discuss. The tissue level implant, based on Dirk's article, has been resistant to periimplantitis more so than a 2-stage implant. Why? No microgap at the crest. The biologic width is formed supercrestally on the machine, on the smooth collar, and there's no irritant at the crest. The hybrid concept is a bone level, but whatever implant you decide to do, more and more companies now are doing this, and people are realizing that this makes sense. So each implant must be judged by its own long-term multi-center study with survival rate and success rate, not just that it's integrated, but success rate without bone loss of any significance. And that's what I mean by success rate, not just survival rate. So where are we going? Where are we going? Faster, easier to put in, cheaper, better, okay? But that's the short term is better, maybe integration. It could hold load sooner. But long term is going to be resistance to peri-implantitis, as Björn already mentioned. This is the main event for the long term. And that's what we have to look at. So we're here to stay with implants. It's magnificent, but we must be cautious about picking the right surface at the right time. I thank you, and it's been an honor, and I look forward to having you. Thank you so much for having me.
Thank you. Thank you very much, Dennis, for such an excellent lecture. Not a surprise at all coming from you, but certainly very impressed in how awake you are at 4 o'clock in the morning. You must have had a lot of training on this.
Yeah.
We'll come back to you with the questions.
Okay. I made believe I was in Spain and just went to dinner at 2 in the morning. You know?
Sure.
You taught me that, huh? You taught me that.
Thank you, Dennis.
My pleasure. My honor.
It is with great pleasure now that we are going to introduce Professor Klaus Lang. Professor Klaus Lang has presented more than 3,500 lectures all over the world. He has published more than 700 scientific papers in peer-reviewed scientific journals. For 26 years, he has been the editor-in-chief of clinical oral implants research. But what you don't know is he could have been the most famous international opera singer. And he wouldn't be here with us. He would have been with Montserrat Caballé for many years, most of his life. He is most welcome now to present our next lecture, and he will be speaking on implant stability and osseointegration, what we knew and what we know. You are most welcome to the podium, Professor Lang.
Thank you very much, Jaime. Thank the organizing committee for having made me part of this exciting prime time emission. We are the European Association of Osseointegration, meaning that on our logo is osseointegration, basically a biological principle, and we've heard it, how it is defined. It is defined on a light microscopic level. And I decided to go back 30 years and take you on a trip through the development up to today. Because osseointegration as a phenomenon is one thing, but what did we do to improve or to speed up that phenomenon? You know, years ago, the dentists were always eager to place implants. And they placed implants into the body way before osseointegration was a fact. And the healing was by fibrous encapsulation. We just heard from Dennis Tarnow that Linko implant, the blade implants, were an era in which implants were used for prosthetic rehabilitations. Now here you have such a healing, and you can see the connective tissue goes all around. And that is, of course, far away from osseointegration. When you stain this with fluorescent dyes, you can even get the impression that the implant is resting in a hammock, like an artificial periodontal ligament. It looked good, and it was also functional in some ways. But what we don't say here is that these fixtures basically got infected very easily. So, the new concept, I would say basically the revolution, because it came by the snap of a finger, is the osseointegration, or the direct bone-to-implant contact. And we own this to two researchers. One is most likely always a little bit put in the background, and that was my teacher, André Schröder. But as said by Christoph, these principles were discovered independently. It was not the time for the internet yet. And Brånemark had done studies on wound healing in dogs, and then he observed that his wound chambers were hard to remove because they had also integrated. Now, it happens to be that these were made out of titanium. So that was his discovery, and his benefit or his credentials have to be given to him that he made the switch to the clinic. Schröder worked with the Association for the Study of Internal Fixation with the orthopedic surgeons, and those had a paradigm where they wanted their fixtures to be incorporated better. And through that, they discovered a sequence of events of how bone was forming in the gap between a fixture and the bone. And it was worked out that this follows a very clear sequence, first by woven bone formation, that is then releasing signaling molecules that then deliver also perivascular stem cells that enter the osteoblastic lineage. And you can observe that these structures form always around vascular networks. And the vascular network is actually determining the primary scaffold and sponge work. So here you can see that very clearly, that the new osteoid, which is the red part, is forming around the vasculature. So what we did 30 years ago, we rinsed out a canal and removed everything because we thought it had to be clean. But actually that's wrong, because in every coagulum you have 10,000 of the bone morphogenic proteins and other signaling molecules that are needed for the osseointegration process. Basically, it's a very dynamic process that arises from the base plate, from the through appositional bone formation. So we start out always with the primary scaffold, which is woven bone. That then is reinforced by parallel fiber bone as time goes by, and it's a true maturation process that ends up with the formation of primary osteons. This is gap healing, but it's also the gap between an implant and the bed of the implant. Well, so far one seemed to have developed or discovered the principle of osseointegration in the 80s. But why did Linko implants, as I showed you, not osseointegrate? Well, I don't think it was the form. It was truly the material they were made out. The material that matters is that the resistance to corrosion has to be very high. And you can see on this graph that comes from Steinemann and experimental studies that shows 3 fields where you have on the right-hand side a group of materials that are characterized by very high resistance to corrosion. And you can read there platinum, tantalum, niobium, zirconium, and titanium. actually titanium being the highest, or titanium alloys, and you already see the zirconia implants there. So these are biocompatible because of their high resistance to corrosion. On the other hand, on the left-hand side, you have toxic materials. And then in the middle, you have those who are tolerated. And they heal through fibrous osseointegration, fibrous encapsulation, I should say. And what is there on the right is steel alloys. And most of the implants of the courageous dentists before the 70s were made out of stainless steel. And that's why they didn't osseointegrate. Then came an era where one tried to improve the osseointegration process through coatings. And what better to take than hydroxylapatite, which is part of bone. So the hydroxylapatite coatings were tested in vivo, and one found out that the hydroxylapatite was occasionally resorbing, and the osseointegration was lost again. So the hydroxylapatite coatings disappeared again. Dennis Tarnow was alluding to the fact that most of the osseointegration was documented by histological analysis. And he mentioned also that there's very little about the electron microscopic or ultrastructural union between bone and the implant. And we had the luck in the early 90s to have Max Lisgarten from Philadelphia for 2 years in Bern. And he initiated a study where he looked at the electron microscopic level of this union in non-submerged titanium-coated epoxy resin implants. Why epoxy resin implants? Well, because to prepare ultrastructural samples, you need ultra-thin sections, 1 micron. And that you cannot do with regular titanium. So one had to use a trick. And one chose an epoxy resin implant, and that was then coated with titanium vapor. And now we can go and have placed these implants. You see the epoxy resin is the key thing, but when you look at radiograph, you see the outline of the implants through the titanium vapor. Needless to say, when we go in now to higher magnification, this is still undecalcified. You see that there is really an immediate contact. And there is no layer in between of proteoglycans and so on. It is truly, when we decalcify, you see the collagen fibrils directly on the titanium oxide. So this, to me, is actually the ultimate documentation of osseointegration. Now, for a while, we always had slides prepared about 3 months after implant placement. And in the early 2000s, I had the opportunity to spend a sabbatical in Gothenburg. We said, well, nobody has really looked at the sequence of events. So we created a model there with Thor Berglund and Ingvar Abrahamsson and Jan Linde to look at the sequential events. How does osseointegration happen? And what we did here, we had prototype implants that looked very closely to the commercially available ones, both with a roughened or moderately rough surface and also a turned surface. So here we come into the discussion, what is better for the osseointegration process? Now, you see these implants had, through their design, a chamber that was then filling with bone, and we could study in the chamber the bone formation. Now here are the implants placed into the beagle dog. Then you see they heal uneventfully. This is 3 weeks, and this is 3 months. So very nice healing, and you can see they are clean because they are taken care of every day or every second day for the biofilm removal. Now here I'm going 4 days of healing. I won't show you all the steps, but this is 4 days, and shows you that basically in the chamber, in the red frame there at higher magnification on the right, you see that there is a coagulum that is now materializing. And you see still bone chips, or let's say debris from the turning in of the implant that is there. And it provides, again, the biological juices that we need. What you also can see is that there is some resorption. And the resorption is where you have pressure on the bone. So you see that around the spikes, it starts to resorb. Now you see this 4-day in higher magnification, a very orderly, well-organized primitive connective tissue, a granulation tissue, abundant in vasculature, as I said before. And when we compare now that at 4 days of a turned surface, it looks completely different. It looks a mess. It's a mess. And obviously, the moderately rough surface was preferential, and this here probably takes some more time. As a matter of fact, it does. I show you now what happens after 1 week. You see that there is contact osteogenesis on top of the implants, and there is distant osteogenesis, and these are united through the trabeculae that emerge in this particular area. Now, if I show you the same for the turned surface after 1 week, you see that we do not have any connection with the implant surface yet. So it's all connective tissues. Basically, that is all distant osteogenesis. And this is then 2 weeks for the moderately rough surface. You can see a nice coating of new bone around the implant. So this and other studies showed us that we can rely on osseointegration. And if you have such a thing, it cannot dissolve by a chewing force. It will have to be dissolved through a process that breaks down tissue. Now here we go to the turned surface at 4 weeks and SLA, or the moderately rough, at 4 weeks. And again, you see the difference at 4 weeks. It starts to level out. We have the first bone-to-implant contact also for the turned surface, but you have a complete coating in the moderately rough surface. This is just for completeness. 8 weeks. At 8 weeks, you do not see any difference. Of course, I don't show you here the figures. They come later. And at 12 weeks, the 3 months famous documentation, which we occasionally get from industry, looks exactly the same. So the difference is in the early healing. And we learned a lot from that. And when I now measure the bone-to-implant contact, you can see that after the 3 months, I have a level that is from about the 4th week onwards at a maximum of 65%. That is osseointegrated direct bone-to-implant contact with a moderately rough surface, while with a turned surface, we're down at around 40%. But that's enough, because the 40% may be okay for implant stability. This is, of course, highly statistically significant difference. But what you can say, you may be able to load earlier when you have an osseointegration that happened very rapidly. Now, then there was an era of attempting to improve the osseointegration through coating of surfaces, also through nanotechnologically modifying. And I'm quoting here the studies that Berglund has done on the Astra system. I shouldn't mention any manufacturers, but they were the first to present the fluoride-modified surface. And I'm just giving you the results here. Of course, that was also done in dogs, and it was done with the micro-threaded or thioblast surface as a control, and the new OsseoSpeed surface that is available still today. When we look at the biopsies, and now we knew we had to go in at 2 weeks and at 6 weeks, because that was the interesting times, we see that at 2 weeks and 6 weeks, I just ask you to look at the lower figures. You have on the test, the fluoride modified surface, 56% after 2 weeks, and 43 only in the control. So there's a difference of 13%, and that's statistically significant. So it is indeed an implant that brings you faster osseointegration. And also, at 6 weeks, it levels out again. So this is very much early in implant incorporation. Now, other companies have not been lazy. They have also modified the surfaces by nanotechnologically making them, for instance, here in the SLA implants, making them hydrophilic instead of hydrophobic. And this is now the time in 2011, so 20 years ago, no, 10 years ago only, that we have the first human biopsies in a sequential study, the first human histology. And we found out when we placed test implants in the retromolar area, which the dimensions of that device are shown there. When we take that and retrieve them with a trephine, you see that this will then heal, but we have now a coat around of bone around the implants to study in histology. And when we did that with Dieter Bossart and the whole crew in Bern, we extracted these by trephining them out, and there is about 1 millimeter around every implant, and all volunteers, our students and so on. But you know, you can be volunteer or volunteer. So we paid them, of course, for that. So the healing periods show you a sequence of events up to 6 weeks. And I'm showing you only 2 data points, and that is the 2 weeks moderately rough surface, or SLA, at a higher magnification. In human histology, you can see you have exactly what we used to have after already 1 week in the animal. So the osseointegration process takes more time in the human. And you see these nice trabecules, contact osteogenesis. And if I show you now just some extra slides to document the human histology. Now we go to the newly modified surface, and indeed in the modified surface we have a more intense coating that occurs at the 2 weeks interval. So this shows you that yes, we can speed it up with modifying the texture of an implant. And when you look at that, it's very nicely documented. Of course, you don't do human biopsy studies in that magnitude every day, but I think the information is here, and it gives me confidence that I may have a principle that I can apply for coding at an earlier stage. It doesn't, the difference of or a SLA modified, SLA active surface is not a tremendous difference, but there is a difference, and it is after 4 weeks in humans. And the difference is 16%, as you can see. So is that relevant? When after 6 weeks you are at the same end, is that relevant? Do you need that? Or does it incorporate anyhow? Well, there is a wide open field for speculations. And it was, of course, used in arguing to sell the more expensive SLA active surface. But you see, both are working. Now I show you the last thing a little bit in the future. What can we expect? We have now 22, 23. And you see here a title, Sequential Osseointegration of a Novel Implant System based on a 3D printing in comparison with conventional titanium implants. So apparently 3D printing is being also used now to develop implants which are much cheaper than the conventional way of turning them. And of course, these need to be tested. And we have done a study during the Corona time or just before, and it is now finished. The manuscript is going to be submitted on Monday. And this is in 8 beagle dogs done in Lugo. And what we had, dogs with an intact dentition and a healthy periodontal status. It's a split mouth design, randomized experiment, 4 dental implants per hemi-mandible. And the healing times are 2 and 6 weeks again. Now, when we look at that, you see these 4 implants. The 2 middle ones are the new printed, 3D printed ones. And needless to say, their surface is not the same as a turned surface. And then we have a control implant on the right and on the left that are normally turned implants. I'm not going to tell you which manufacturers these control implants are, but you can just see we have now seriously gone through an arsenal of techniques, micro-CT, methacrylate histology, descriptive analysis, and histometry. Well, of course, we measured these distances that you can see in good histology. And if I give you just an impression, it is to show you this is a field that is being developed to make the implant cheaper.
Professor Lang, it is my sad duty as moderator
to stop me. Yes, I will.
Yeah, I know it's impossible to summarize 30 years in 10, 12 minutes or in one question, but we need to go on to attend the questions.
Yes, okay.
Sorry.
I will stop by saying I have only elaborated on implant stability and on the osseo-integrated part. But there is a soft tissue collar around, and that has also been looked at, that belongs to the tissue integration process and is very important. And I was so happy that I've heard it from Björn Klinge saying here, the placement is very predictable, but the maintenance is not predictable unless we have supportive care. And with this, I conclude my presentation, and thank you very much.
Thank you. Well, thank you very much, Professor Lang. I know how big effort it is to summarize all your knowledge in these 12 minutes, but we will go now to the questions. We are starting now the discussion, and the first question goes to Professor Hämmerle. Which implant placement protocol have you been mostly using in the past 30 years, Christoph?
I think it's late placement. The reason being that when we started out using implants, we treated a lot of patients who had lost their teeth a long time ago. So they were healed sites. So people had lost teeth. Today, the protocols have changed because usually we have to replace teeth that are doomed for extraction.
Yeah.
So late healing as a first step. Then maybe there was a phase with delayed healing, so soft tissue healing for some time. We had a lot of referrals for aesthetic cases. And maybe in more recent years, also more immediate placement. And I think the decision on which protocol to use has a lot to do with the local tissue situation, the risk tolerance of the patient, and also where we are in the oral cavity. So in a molar site, we can let it heal and place an implant later and maybe do an early type of loading because it's not so important to have a missing tooth. But in the anterior side, to have a final or a provisional reconstruction on the implant at least is very critical to the patient. So there's a strong effort towards immediate placement of implants at the time of tooth extraction. And I think these protocols are also very elaborate. And then the premolar area is probably the area which is easiest. Also, immediate placement in situations where the tissue situation is favorable. So this is much more difficult to manage today because there are more options, more possibilities. It's more demanding on the diagnosis and the patient management, as well as the communication with the patient, within the dental team and the dental technical work.
Thank you. That was very clear, even for a prosthodontics. Thank you. Helena.
Yes. So let's travel again to New York City. Dr. Turner, you give us an overview of implant dentistry, not in the past 30 years, but in the past 60 years. And when I was at NYU, we had lectures with Lenny Linkow, in which quite very, very interesting. Do you think that nowadays we will still have room for blade implants?
I think there will be a chance for a blade, like in a full arch, where you have a thin ridge, instead of doing a ridge split, where you put the blade in. I think Virtualati's doing that. He's calling it, instead of a blade, he's calling it a wedge.
Yes.
So it could be narrow for a single tooth, but I think as part of a regular full arch case, instead of doing a big augmentation, if you can put a blade in a single tooth and splint it all the way around, we may see that this may be, and they can be made two pieces now with screw down, I think, and texture. I think that the same as any other implant. I think the answer will be yes. I think that it's an emotional decision not to do it. I think it's just like we're using narrow diameter screws, it'll be the same. Okay?
Perfect. Thank you so much.
Professor Klinge, all of us have noticed your key points, and audience have noticed something on that as well. So I will go with really nice question. Someone from the audience would like to ask you if in the following 30 years, we will still keep discussing on how to install implants, like navigated versus hand, brain-driven, or we will be looking for how to keep our implants healthy. And I would also like to merge another question to give a guidelines on how to probe around implants, or whether we need a sterile probe for each implant or whatsoever. So keeping our implants healthy and how to diagnose and probe around them, please.
One thing that needs to be addressed also is, of course, not to install implants in patients with ongoing periodontal disease. And you can see that also on conferences of this size, that some renowned presenters show slides where there's obviously signs of ongoing periodontitis in these cases. And that should be a total no-no. So treat the periodontitis first and then do the implant procedure. And on that route, of course, if it is a former periodontitis patients, they are aware of, or should be aware of, the home care. Because single visits to the dentist or the dental hygienist, of course, as important as they are, but it is morning and evening at home that is the critical issue. And I think one of the key issues is to find ways to bring this message to the patient. It's their teeth, their implants. It's not that they're coming to the office and leaving the responsibility to the dentist. Then there are at least 265 different probes available with coatings of titanium or plastic or this and that, and no studies have proven one probe to be kind of dangerous to probe. So rather use the probe than try to excuse yourself that you didn't have the right probe. I think that is the simple answer.
And the very practical part of that audience question, should you have a separate sterile probe specifically for the implant?
I think that in 10 years' time, maybe there has come an abstract on the EAO showing that there was some benefit to that. But
right now, there's no scientific basis for that.
It's important to probe, right?
Yes.
So
if
we have...
You should have a probe, and you should use it. Simple as that.
So if you have a probe at the office, please use it. So we have more questions from the audience, and now is for Professor Lang. So Klaus, the question is, what is the highest bone-to-implant contact we can achieve today? Can we still go higher?
That is a very ticklish question. Of course, you can always speculate that you could go higher, but you don't need 100%, because don't forget, bone-to-implant contact means mineralized bone-to-implant contact. In between, you have marrow. Yes. And marrow is also bone, but it is not mineralized. So I would say we can expect around 60%. Okay. When you calculate from the level where the implant enters the bone down to the tip of the implant, around 60% for the moderately rough surfaces and a little less for turned surfaces. But that is enough. It is enough even to have 30%, because studies have shown that all the Brånemark group had these very smooth, or let's say, turned surfaces, but the implants didn't fall out. I mean, they were also in situ for many, many years. So one should not be afraid of thinking that the implant is not good enough. The reason why an implant would have an early failure is probably a management failure, that the bone has been heated or the bone has been loaded immediately with very high forces or something, or that there was a pre-existing infection. I have seen implants placed in areas where there was a huge endodontic lesion before and just immediately placed in this. I'm not surprised that that is an infection. But basically, we can say that the implants are very predictable today in the healing.
Okay, thank you so much for your wonderful answer.
Thank you. Professor Hämmerle, what material would you choose for the final oral rehabilitation on implants? And the second part of the question could be, what is the importance of the opposing dentition in the outcome?
I grew up with using PFM reconstructions. And I can say today, PFM is still a type of reconstruction which is amenable. There's some reasons today maybe to change to zircon, ceramic reconstructions, lithium disilicate, and zirconia. Lithium disilicate I would use in single crowns, maybe short span bridges very carefully, but primarily for single crowns. And for larger reconstruction, we can start to work with zirconia. But we have to be careful. There's like a hype word, zirconia. I'm using zirconia. But there are different types of zirconia, and they need to be managed in a correct manner. So we have the 3, 4, 5 molar, and as we increase the translucency and the aesthetics, for us to use it, that it mimics teeth, the physical properties decrease. So we need to be very careful there. One way to get around this, having monolithic zirconia, is to do surface staining, but there are no long-term data of how durable this surface staining will be. Another one is to micro-layering. And doing this, we can avoid some of the chippings that we see with PFM. So with zirconia, we still need more longer-term documentation, especially on how to handle the different types of materials within the zirconia family. With PFM, we have a lot of documentation, but we also know that there is frequent complications on the technical level. So it's an area of intense development and research, which is really needed.
Thank you, Christoph. Very clear.
Very interesting, and there is so many space left for the research, also for the discussion. But as we need to wrap up this session, we would like to ask all the speakers to send us the short message, like what would you change now after practicing 30 years of implant dentistry, and what would be the key message after this session of the experience on 30 years of implant dentistry. So we would like to ask all the speakers to share with the audience and with us this short message. Professor Lang, please.
I'm sorry I have to step on a neighboring turf. I think what we have to impose on our colleagues is that implant dentistry without maintenance is a no-go. We have to control the known risk factors. And let me be quite frank, there is not very hard evidence on every risk factor. For instance, we do not have the data that show us that control of smoking, I mean smoking cessation, is truly going to improve the prognosis of an implant. We don't have it yet because the studies have not been designed like that. But I think it's risk factor control. Among the most logical one is maintenance.
I'm writing that one down. Risk factor control, very good.
And Professor Klinge?
Klinge, short one.
Number one, try to understand that the mouth is a part of the body and that can affect the whole body. Secondly, please try to understand that the oral health is your personal problem as a patient. Not only problem, but responsibility. And you should take that responsibility seriously. Look yourself into the mirror in the bathroom morning and evening and smile at yourself.
Smile.
And make sure that you handle this correctly.
Wonderful message. Shall we switch to New York first?
Yeah, let's
Dennis,
go to New
are
York.
you still with us? Key thing to underline,
I'm still
key
here.
message?
The coffee works, so I'm still here.
Yes.
I agree with all of my colleagues, and if you hear anything, it's one, know what you're doing in terms of, picking cases that you're capable of. Get proper training for somebody starting out. But if you look at the same thing that we're all talking about, it's thinking biologically, whether it be about peri-implantitis, whether it be, anything resistance to disease, systemic disease, reaction of bone to, everybody's talking about the same thing in different ways. If you think biologically, it'll separate you from the strictly mechanical thinking of like a carpenter. You're not carpenters, but you're into biology. That's why you got a doctor in front of your name, and never forget it. I leave you with that. Think biologically.
Thank you so much. Thinking biologically. Christopher.
I think integrating, moving from Formula One into the real world. So what we do at the Congresses is Formula One. We see specialists, we see universities showing documentations, and this is what we base our treatments on. It's very important. This is where we want to go, where we want to be. But implant dentistry is happening in private practice. And we don't know enough about what is happening there and where the stepping stones are. So we should open our eyes and have a better communication with the people at the front lines who do it every day in the wild world with all the pressure they're subject to. So I think there we can gain a lot more information for improvement every day for every patient in the world.
Beautiful message here on this stage. Jaime, concluding words from your end to end this session.
I would like to thank these giants, these wonderful speakers, for teaching us for 30 years to this day. I would also like to thank my co-moderators, not in my highest dreams would I have been so happy to prepare this lecture together, this session, together with them. And of course, Professor Helena for organizing this wonderful Congress for the EAO, and certainly the EAO board for putting all this together and guiding this society, which is certainly, if not the best, one of the very best in the world.
Thank you so much, Jaime Jill. Thank you to everyone involved here on stage. Thank you for watching both here in the room and online. Let's make sure we keep learning for at least another 30 years.